السلام عليكم دكتور محمد.
وعليكم السلام ورحمة الله وبركاته.
حياك الله، كيف الحال؟ الصوت جدا واضح؟
جدا ممتاز، الله يعطيك العافية.
ممتاز. طبعا انا الان ما فتحت الروم. طبعا خلي بس اخليك كو هوست اول شيء. تمام؟ مور ممتاز. طلعت لك؟
ايه تمام.
طيب خليني اسوي بعض الاشياء انه نخلي الناس لها رول معينه. مور unmute themselves. no start no because remain mute upon entry. yes. اوكي.
طيب انا ودي اجرب
طيب.
شيء دكتور عبد الله، اللي هو
شو اسمه، هو طبعا البيدا مودريتور. طيب ماشي بك عبد الله الان. خليني اعطيك الصوره. You are sharing the screen.
طيب.
ممتاز، واضحه جدا جدا. بس هل كليكت على الليفت بيكون عشان يعني الصوره ما تلخبط في يعني، لكن اول دن الصوت جدا
سم
الصوت جدا واضح. طيب خليني بجرب معك بولينج كويستشن.
ممتاز.
اعتقد انك ككو هوست ما يشتغل معك، لكنه بجرب.
اي كان دكتور عبد الله.
يو كان لانش ذا كويستشن. او ممتاز ممتاز. شايف الان انا قاعد اشوفه وخلني ممتاز. and you can share the results.
اي اكسلنت.
ممتاز.
ممتاز.
I will drive this or you can drive this.
لا، if you can drive it that will be better.
خلاص اتولى هذا.
اكون انا يعني
انا طبعا انا ان كول، لكنه I will deal with it. لكنه عرفت البروسيس سهله.
يحتاج تطلع الله يساعدك.
ممتاز. طيب ننتظر عبد الله الين يشبك، لكنه الصوت واضح. الصوره جدا واضحه.
ممتاز.
ما في اي مشاكل. اوكي، تبغاني اخليك الهوست محمد؟
لا، خليني كهوست مرتاح، يعني الامور تمام. يعني يفرق.
لانه انا اذا انقطع الاتصال قد اتوهق يعني. شو اسمه. ف يعني انا نكول يعني ودي ان يكون الكونكشن جدا جيد. فممكن اخلي عبد الله هو الهوست ويكون عند ما بعد دخل عبد الله. انا بعطيك الان. عبد الله يقول انا حاولت ادخل ما لقيت. قاعد تشوف عبد الله في البارتيسيبنت؟
ما حصلته، قاعد ادوره قبل شوي.
اوكي.
هو داخل باسمه لاني اشوف في ايباد، في اتش بي، في
خلاص دخل وجدته.
ممتاز.
السلام عليكم دكتور عبد الله. طبعا في تقريبا 43 participants.
نعم.
عبد الله قاعد دخل. او يس so I will make him co-host. صح. No make him. السلام عليكم عبد الله.
عليكم السلام. هلا كيف احوالك؟
اخبارك طيب؟
الحمد لله تمام. كيفك انت؟
تمام يا حلو.
طيب
دكتور محمد كيف احوالك؟
نعم الله يرضى عليك.
الله يسلمك. كيف احوالك؟
قبل لا يطفي اللابتوب على الشاحن. اوكي. كم باقي ونبدا دقيقتين
تقريبا.
طيب. خلي بس اشوف عبد الله open the camera if you don't mind.
ايه
شو اسمه؟ ممتاز حلو. الصوت حقك واضح جدا. اوكي عبد الله كيف الكونكشن عندك جاهز؟
الكونكشن ممتاز انا عندي.
ممتاز. عادي لو خليتك هوست وطبعا في بولينج موجود. اوكي وانا يعني قد يجيني اتصال في اي وقت علشان لكن انا بكون موجود الحال اكون موجود كل الوقت.
طيب تمام تمام.
طيب whenever you guys ready just update me to open the room.
طيب خلينا بس نوصل السماعات.
خليني اشبك الشاحن و علشان نبدا ان شاء الله. بسم الله.
البول كويستشن موجوده؟
موجود ايوه
موجود. نعم
تمام.
ان شاء الله راح تكون تقريبا 40 minutes at total. يعني don't want to make it longer الزوم حسها مملة اكثر. وان شاء الله we'll have time interaction. صحيح ولا لا دكتور عبد الله؟
تمام يعني take your time. احنا طبعا عندنا زمن to 1.5 hour يعني up to 10 o'clock up to 9:30 10 o'clock ما في مشكله.
ممتاز.
يعني
لكن هل راح يكون في تايم للانتراكشن questions
انا اعتقد التوبك جدا جيد للانتراكشن. يعني هو اعتقد راح يعني يفتح مواضيع كثيره and we'll expect a lot of questions ان
شاء الله باذن الله.
بعون الله. جاهزين يا شباب؟
اوكي يلا open the room.
Okay, so I will admit all and
mute all.
طيب. طبعا الكاميرا stopped عبد الله.
stop it. Yeah, stop my camera.
Okay, طيب. بسم الله الرحمن الرحيم. So I'll admit all
Dr. Abdullah, I will make you the host. Okay?
Yeah, okay. Okay. So now it's time to start. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to our monthly academic activity in Saudi Critical Care Society, Pediatric Cardiac Intensive Care Chapter. We resume our activity now after a base for the Eid vacation for 1 month. Almost now we didn't have an activity. And we are pleased today to resume our activity with one of our best speaker, Dr. Muhammad Al-Maziyad. Dr. Muhammad Al-Maziyad is a consultant in pediatric critical care in King Saud University, King Khalid Hospital in Riyadh. He's going to present today to us a very good and interesting presentation about a topic which concerns all of us, not only the cardiac critical care people, also all the pediatric intensivists and pediatric intensive care caregiver. Dr. Muhammad, the mic is yours. We will start our presentation, I think, with some pool questions to let more audience to join us, because it is just Aisha prayer finished just now. Dr. Muhammad, mic is yours. Hello. Asked to wait. Have to mute all, and then Dr. Muhammad, unmute yourself, please.
تمام. الصوت واضح يعني دكتور عبد الله؟
Yes, clear.
طيب.
Go ahead.
First, I would like to thank the Saudi Critical Care Society and the Cardiac ICU, Pediatric Cardiac ICU chapter for their invite. And thanks, Dr. Abdullah, personally for your connection. And I'm really glad to have this opportunity to present for you today. Today, inshallah, we're going to be presenting the concept of chronic critical care illness, specifically in the pediatric population. And inshallah, we'll try to shed some light on the our local context here in Saudi Arabia about how are we doing with the chronic critical illness, how much we know about this population, and how much we are providing part of the care that we provide to this specific population. Just in the beginning, a quick introduction. I assume most of us work in critical area, and the critical care medicine field has been developed and traditionally known to be focused mainly on stabilization, acute care, resuscitation. We are used to deal with and manage patients with rapidly, quickly changing physiology. We deal with a deranged physiology usually. Our specialty is a fast-paced, high turnover specialty, high volume, rapidly changing patient status. You know, we follow patients around the clock. Change the case of the patient might change from 1 hour to the other. So from where the word chronic is coming, and how did we end up here to include the word chronic in the same sentence as critical illness? And that hopefully we'll try to shed on and see. So just how much do usually the mortality of pediatrics? This is an estimation of the mortality of pediatrics in the 19th century. Of course, it's a mathematical estimation, and they estimate it to be more than 30. However, over the course of the time, specifically in the mid of last century, mortality has improved and dramatically has improved, specifically in North America and Europe. As you can see, the numbers are pretty low, 4 and 5. And that mainly is attributed to preventative medicine. Most of the preventative medicine, like development of vaccines, improvement of neonatal care, and improvement in and ease access to care. And this trend continued until nowadays. So now the global mortality of pediatrics is around 5 to 6%. If you can see, North America and Europe is around 0.5%. And in Saudi Arabia is around 1.5. These numbers are from 2015. So again, this improvement is really related mainly secondary to preventative measures. Everybody works in pediatric knows there is many diseases that we don't see anymore. Very rarely to see measles, mumps, very rarely to see meningococcus, and so on and so forth. And that's mostly related to improvement in vaccine. So clearly we have a downslope trend of mortality in pediatric worldwide in all high-income country, middle-income country, low-income country. So we clearly have a trend of decrease of mortality. And as I said, mostly this is related to this preventative measure. Here in Saudi Arabia as well, this graph shows the mortality in the 70s to 2019. And again, there's significant decrease in the yearly mortality of pediatrics. Again, it's mainly the preventative part of medicine, development of treatments, and so on and so forth. But there is another part to this, is actually the improvement in critical care medicine itself. The development of critical care, the improvement that we had, improvement in ventilations, resuscitation science, improvement in life support therapy, all this has contributed to the improvement of pediatric mortality. But we need to ask this question: what's the cost of this survivorship? So we know people live longer, pediatrics patients live longer, but in which cost? Everybody knows now, if you compare neonatal death from this year to the 70s and 60s, we have significantly better outcomes. If you look at the neonatal mortality in ICU, it's significantly better as well. However, there is a cost for this survivorship. And we need to ask ourselves, what does this cost mean to us? And these survivors, how do they end up? So this graph shows the data from one center in North America. They had reviewed the home ventilation program in the 90s. So from the beginning of the decade to the end. And there is significant increase in the patient enrolled in the home ventilation program with variety of reasons. Here included neuromuscular, COPD, post-TB. These are adult data. This trend continued. This is looking at almost 20 years since the year 2000. Again, this is a multi-center looking at long-term ventilation with an upward trend for number of patients utilizing long-term ventilation, whether invasive mechanical ventilation or non-invasive mechanical ventilation. So we are really seeing a new population that has evolved as a consequence of improved mortality. These patients used to die secondary to fatal and incurable diseases. and now they are surviving for longer period of time with rest of the complication, the treatment they receive, complication of their underlying disease. And the most common example that we always talk about in pediatric is the premature babies. So 28 weekers, 27 weekers, 30 weekers, they survive now. They survive to their 20s, to their 30s. And definitely their baseline physiological status is not comparable to a healthy person. So if you can, it's this really new population coming in between two populations. The first is the population that respond to the critical illness, the critical care intervention. They receive it for short or long period of time. They get better. They almost go to their baseline with reasonable functional status, and they go home. And the other group is where this treatment is futile, is deemed to be illness deemed to be incurable, and the critical care intervention will be futile, and eventually they will die. So we have this new population that's becoming in between. They are dependent on the prolonged support, whether ventilation or other, with no clear duration of this. It's not clear if this is going to be permanent. Some of them, they might end up having permanent need and dependency on this life support. Some might have shorter support. So this population has really a specific need. So this is a graph, just another representation of what we were talking about here. So if you can see, it's the critical illness onset. The patient have critical illness, they admit to the ICU, they receive life support. The green line represent the patient who improve to this support, regardless of how long they take. They improve, they go to almost near or normal functional independence. This is not the patient we are talking about. We are really talking about, it's an area between the yellow and the red line. So these patients still depend on some sort of life support, whether it is ventilation, whether it is mechanical support like LVADs or other intensive medical interventions that they need to continue, whether in a home or a long-term ventilation facility. And it's not clear for how long they will need it. And it's not clear how of their functional independence they will regain. So here we are dealing with a specific separate population, has its own consequences and its own demographics and prognosis. In the adult literature, they have a more clear definition of chronic critical illness. It's mainly based on the need for chronic ventilation. So they define it as any patient who stays 8 days or more in the ICU and meets one of the following. Either he needs prolonged mechanical ventilation, tracheostomy, sepsis, severe sepsis, and they include here wound infections and severe wounds, all multi-organ failure that needing support. Let it be dialysis, let it be peritoneal dialysis, and so on and so forth. So do they represent a distinct population? Yes, they do. They actually consume significant number of resources, significant number of beds. They have usually worse outcome. So in the adult literature, the expected mortality at 1 year after discharge for a patient with chronic critical illness is around 80%. And around at 6 months as well, that's around 50%. They will pass away. So here we are talking about significant prognostic importance of the definition and diagnosis of patient with having a chronic critical illness. So is it applicable to pediatrics? I think that's an important question that need to be addressed and thought of in a more deep manner. So we have few questions we're going to go through. Is can we really use length of stay alone as a factor to define pediatric critical care, pediatric chronic critical illness? Are we going to use the same adult cutoff? If yes, why? If not, why as well? Is having a trach necessary to define pediatric chronic critical illness? We know in adults they usually trach patients earlier, more easy than we do. And therefore, it's a significant criteria in their definition. Is it the same situation in pediatrics or it's different? And then we need to go through some pediatric unique considerations. Before we go there, I just want to ask you to answer this question. I'm going to activate the pool. I think it's already launched. I'm just when I launch it, I'm not sure if it's new or old. So I just relaunched the question pool. So when do you consider a patient having a long stay? 10, 14, 28, 3 months? What do you think? I'm just going to give you a minute until we get most answers, and then we'll start. I have only 15% participant, so if we can get that bigger number, that will be good. More going to be more realistic and more representative. Few more seconds for last answers, please. Yeah, people are picking up now. Excellent. All right, so we have around 30% response. I'm just going to share results with you. I hope it's obvious. So really, we are divided. We are divided between the 4 answers. You can see there is no clear consensus. Most people said 28 days, but really it's very close to each other. Okay, so length of stay is really the cornerstone in the definition. It's very important. We cannot ignore it. But then comes the question, what's the cutoff? You can see that we are now almost in disagreement. We have 4 options. We're almost equally divided between these 4 options. Can we use the same number? Is 8 as adult is too short? Some people say yes. It's as the duration of mechanical ventilation and the consequence of long mechanical ventilation in pediatric is not necessarily as bad as an adult, as pediatric are more resilient, and this is more accurate and more true in the neonatal period. So actually, most babies who's premature will get ventilated for a significant number of days. Here I mean invasive and non-invasive ventilation. So we need to take this in consideration when we define pediatric chronic critical illness. And looking at the literature, they are as well as divided as we are in our pool. It has ranged between 12, 13 days to like 3 months, 28 days. But there is a trend of increase of that number, more around 14 to 28 days if you pick something. And this variability coming there is reason for this variability is we are in pediatric dealing with a premature baby or a neonate is totally different from dealing with a toddler, a 10 years old, or a teenager. So the developmental consequences that we have, the development of the population that we are serving, the difference in the developmental behavior, physiology in these groups actually mandate a more flexible and more maybe inclusive diagnosis, a more definition. Then comes the question, would having a trach important to define the critical care elements? Can you exclude someone that if they don't have trach, they're not having critical care, chronic critical illness? Here is another pool that if we can ask you for your answers. Consider you are caring for an intubated patient with an ARDS. When do you consider traching this child? I know it would depend on many things, many factors, but yeah, think of the most common patients that you have. When do you say it's already too long to ventilate this child through a tube, and that would trach him? I'll just give you a minute and see what would be the answer. Yeah, the response is already better than the previous answer, which is a good sign. Give you a bit more, few seconds. People are still answering. Numbers still going up. Correct. So share the result again. So again, as you see, we are divided between the 4, but most people are saying around 14, which is already longer than the adult literature. For many reasons, that's not really the place to discuss that, but we know clearly that adult trach deprivation way earlier than we do in pediatrics. So when do we usually trach our patients in pediatric? This study done in Canada, they surveyed all critical care physicians, attending physicians. They gave them 4 cases, so each group of columns represent 1 case. And they asked them, when do you consider traching this patient? The first one on the left is TBI, the second is GBS 2 years old, the third is GBS 9 years old, and the last one is ARDS patient. If you look at the ARDS column, which is the most far right one, most of them will trach after 20 days, while on TBI, it's almost divided between early and late. But what does this number tell you is usually you are more tolerant to having tube on the patient for a longer period of time before considering traching them. Of course, the age plays a significant role here, and maybe the traumatic brain injury case had a teenager, so this maybe he's been trached earlier. So again, when you consider trach will be the age of the patient, the prognosis of underlying disease. We know we might ventilate a bronchiolitic patient with ARDS for 20 days, 25, a month. He got extubated within a few days, within a week, he's out of the ICU. This is usually unusual in the adult population. The other question is, if we don't trach, do we usually do they eventually need trach? So this study was done in adult actually. They compared early versus late, and they randomized patient to early trach versus late, and 60% of people who went to the late group didn't even need a trach eventually, which gives you maybe support the pediatric approach to wait. Again, we need to consider the difference in the population characteristics between the two groups. What I'm trying to say here is trach per se, it would be not an accurate, let's say, not an early sign to identify patient with chronic critical illness. While in adults, where they usually trach within the first week, 10 days, they actually, that's an early sign that patient will end up having a chronic critical illness. Versus pediatrics, where we wait longer until we trach. So we can't really, we use it in the definition, but it's gonna probably be an early sign or early indicator of chronic critical illness. What other pediatric specific consideration we're going to talk about? I'm just going to summarize about the medical complexity. What about recurrent ICU admission? What about age and development status of the patient? So we know that medical complexity is a risk factor for ICU admission. 50% of patients who admitted to ICU have some sort of complex medical condition. However, complex medical condition does not mean chronic critical illness. So if you see the figure on the right, it has 3 circles. The widest one, the broadest one, is where the child have a special healthcare need. This is a very large group defined as any patient who has either he have or he have the potential to develop either behavioral, physical needs and fragility. So it's either they have or the potential to have. This will include patient with diabetes type 1, for example. They will go into this category somehow. This will include a patient with moderate traumatic brain injury. Will include a patient with simple motor affecting after, for example, traumatic brain injury. Does this constitute medical complexity? Not necessarily. A smaller group of this population is the complex medical condition patient, where they have involvement of 2 systems, more than 1 chronic condition, and they have a medical fragility. But again, this group, yes, they are at risk of ICU admission, they are at risk of longer ICU admission, but they don't constitute chronic critical illness. The chronic critical illness group is even another group within that group. So if you see the 3 circles, patients with special needs, which include chronic medical, complex medical conditions, and within that group, we have the chronically ill patients, chronically critically ill patients. So it's a subset of the critical illness. And that's important. We'll go into why. There's 2 major studies done from the same group in Australia. They looked at the long-stay children in the ICU. They published their institutional experience for like over 20 years. And then they published after a few years multi-center experience for 5 years from each center in Australia and in New Zealand. And they have really an interesting finding. If you remember what we were saying, that adult patients with chronic critical illness usually have high rate of mortality, around 80% at 1 year. In pediatrics, it's the other way around. The mortality rate after 1 year of discharge is around 65% to 70%, which is survivor. Sorry, this is a survivor rate. I'm sorry, that's a survivor rate. So most of them actually survive. And in this study, the 5-year survival was around 60 to 65%. When they divided this into categories of why the patient is chronically ill, the neurological diseases have the best survivability, around 75, and followed by the respiratory cases, including premature babies with chronic BPD, chronic lung disease secondary to ventilation, and so on and so forth, chronic ventilation. And the least survivability goes to the cardiac group. The cardiac group is the middle, goes to the respiratory group, the least survivability, around 40%. Nonetheless, that's quite different from the adult. Therefore, here we have an issue of these patients, yes, they survive, they have chronic clinical condition or complex medical condition, they survive, they go out to the ICU, but they still come back to the ICU. One study showed around 45% of unscheduled PICU admission were for a patient with chronic condition, and they admitted acutely with a condition related to this chronic condition. So an acute illness related to the chronic illness. This constituted around 45% of an unscheduled PIC admission. And in the same study, interestingly, all readmissions or all patients who have two emergency ICU admission, unscheduled admission, were patients with chronic condition. So this speaks to the issue of that it's not only the duration of ICU admission, it's also how frequent do they come to the ICU. We all know that patient who always come to us in the ICU every 2 or 3 months for a reason or another. We see this patient. Whenever he gets sick, whether it's simple or complicated, he needs to come to the ICU, stay with us a week, 2, and then he goes, and then come back after a few months, once or twice a year. I'm sure everybody have that experience. So this must be included in the definition of chronic critical illness. So just to represent what I'm trying to say here. So the x-axis is the time, the y-axis is the setting where you care for the patient. So home, ward, outpatient, and PICU. So imagine this line is the course of a patient. He got sick, acutely ill, come to the ICU, stay a period of time, and then go back to his baseline. He goes home, we don't hear about him again. He follows routinely with his routine. That's different from the other part of the spectrum, which is a patient who is acutely ill, come to the ICU, and he stayed for a very long time with us for whatever the reason is, whether it is chronic ventilation, which is chronic mechanical support, chronic hemodynamic support, and so on and so forth. So this is clearly will constitute a long-stay patient / complex critical, chronic critical illness, which is, this is somehow what's really common in adult. That's what is faced in adult. And what we think here is, we're talking is a bit different, is we have more survivor of patients. So they come to the ICU. He stays for a period of time. He go to the outpatient or ward and comes back again to us, goes home, and a few months later he comes to us. So this population must be included or must be constituted in the definition of chronic critical illness. Age and developmental status of our population. So clearly, pediatric chronic critical illness will influence physiological and behavioral development. How much is that? It's not clear. We don't have, this area is really unexplored, but we know, and clearly there is many reasons for hindering this patient development. And we need to think as well, is this static or progressive disease? So when we define chronic critical illness, we need to consider the age and the development of these patients. You cannot compare a premature infant baby to a toddler or 10 years old with a leukemia or a teenager with traumatic brain injury. Each one of them have a different physiological status at baseline. They have different risk factors. They have different prognostic factors. They have different behavioral response, different physiological response to the chronic critical illness. So therefore, these patients need to be counted somehow in the definition. Lastly, I know we didn't talk about the definition yet, but lastly, what about the onset of pediatric chronic critical illness? I think it's important to have a definition that catches these patients in real time, rather than waiting and reviewing discharge data and labeling them in retrospective manner. Why? Because this implicates, this definition or this diagnosis will have a prognostic implication on these patients that might inform decisions, inform goal of cares. And with clear definition or early recognition of these patients, we will have a clear way and clear communication with the family about the prognosis and what's the implication of what we are doing. Some patients might wrongly view like improvement, let's say, they wrongly view starting home ventilation as an improvement. They think this is actual recovery or full recovery, while it is just continuing what we are doing in the ICU, however, in different settings. So early identification helps us to get a more accurate prognosis, and which eventually will lead for a better communication with the family and more clear decision-making process with the family. Finally, the definition. So that's, I think, one of the main and most informative paper I have read about this topic, published by Shapiro and colleagues. It's a group from the States, from Johns Hopkins and other areas. They try to define pediatric chronic critical illness, and they try to develop a framework for this definition. And they're arguing for it's important for clinical care, research, and policy making as well. So their definition, of course, they overviewed what we already talked about all the consideration, and they came up and suggested this definition. So it's mainly two criteria. So the first, it's any patient who remains for a prolonged period of time or have current ICU admission. They define prolonged period of time in the ICU period as 28 days post-term corrected age. So they somehow excluded the prematures if they get ventilated. So if the patient stays, for example, in the ICU, in ICU for 28 days post-term, or he had 14 consecutive days of admission in the PICU, or had more than 2 acute ICU admission, one of them being long. If one of these patients have an ongoing dependency, they will categorize him as a chronic critical illness. And what do we mean by a dependency? That's anywhere from trach ventilation to G-tube feeding, permanent line insertion, dialysis, DB shunt, and in a cumulative, obviously in a cumulative manner. In the cardiac context would be a patient with an LVAD, for example, and so on and so forth. So criteria is not that complicated. It's really time and ongoing dependency. And I think this is like a start definition, of course. Once there is a consensus on a definition and more studies are done based on this condition and this definition, we will actually understand this population more and probably will refine this definition in a few years. Again, there is no clear consensus on the definition itself. There's only a suggestion by the authors, and it seems to be the most acceptable and widely accepted definition. What about the prevalence? How common is this? Is it common? Is it not common? Surprisingly, it's a significant number of our population that we serve. So if you can see here, there is this study. They looked at point prevalence at multiple points over a period of 2 years. So basically what they did is they went each day of a month, for example, or few days a month. They counted how many patients are chronic, who stayed more than 2 weeks over that number of active patients. That's the dark column. The gray column is the number of chronic patients over the total capacity of that unit. And they divided it by PICU, intermediate care unit, cardiac ICU, and then ICU. For the PICU, around 40% of the active patients or occupied bed are already patient who fits the definition of chronic critical illness. So they use the same definition as we just talked about in the Shapiro paper. And when they convert it to the occupancy, it's around 30%. And it's quite similar between the NICU and the PICU. Sorry, the ICU and the cardiac ICU. Obviously, the middle column is the intermediate care unit, which is obviously caring for a long-term patient, technology dependent. Therefore, most of their patients are actually chronic. Just shows you how significant this number is. Around 40 to 50% of the patients we see are chronic critical illness patients. Is it increasing over time? Yes. This is a period of a decade from 2000 until 2011. In one center in New Zealand, and actually multiple centers in New Zealand and Australia, they have progressive increase in numbers for patients who constitute chronic critical illness, almost around peaking at 80 per year. I hope it's clear to you, but the columns are divided by why the patient is having the reason for admission. So the light gray is surgical, which constitutes the small number of patients. The rest of patients are divided between medical non-cardiac and cardiac, which is medical and surgical. Cardiac as well. What about Saudi Arabia? In review, I found actually only one paper that's looking at this, looking at the length of stay, long stay patients versus active bed and versus total beds. What they did is they had the point prevalence at 2014 and the point prevalence at 2019. And there is a decrease. It was 50% in the PICU in 2013 and 20% in 2019. However, I wouldn't draw major conclusion from this because it's only 1 point prevalence, so it might be skewed one way or another. And in the cardiac ICU has been almost static. Around 30% of the active patients are considered to have long stay patients. They defined it as I believe more than 12 days. Why do the patients stay in Saudi? This is from Saudi Arabia as well, from the same paper. So most of them are staying for a longer period of time for ventilator dependency, 70% of them, which is expected. The rest are divided between inotropic support and other form of mechanical support. What about outcomes of these patients? I'm going to talk about mortality, functional status, and development. So mortality, the overall mortality in the PICU we know is around 2.5% over the last decade, more or less around that number. The mortality for patient who stays more than 28 days is 5 times higher than the average PICU. And overall 5-year survival was 65%. And for a single ventricular physiology patient who define or meet the criteria for long stay patient was 47%, and patient who received bone marrow transplant for oncology reasons was 23% at 5 years. Again, I know these numbers are high for pediatrics, but when you compare to the adult population, it's totally different. And a very interesting study, they compared the mortality in the over the years from 2000, mid-2000 until 2011-12, and they compared if the mortality for long stay patients have improved over that time, and they actually didn't. It stayed the same. Despite having the overall mortality of PICU improving on the same period of time in the same centers, the long stay patient mortality did not improve. And that's what the curve shows here between the two survival curves. That's the same diagram we already talked about and divided into etiology. What about functional? How do they do? Around 40% of children who experience PICU stay more than 28 days had an unfavorable neurological outcome, defined as moderate or severe disability. And if you include mortality on that, it's even higher. It's going to be higher, around 65%. What about development? We didn't know about recovery of developmental milestones after pediatric chronic critical illness. Is really unexplored. There's not much written about it, but probably it has a significant impact. In the ICU, we have prolonged sedation, long sedation, repeated exposure to pain stimulation. They confounded to their beds. There is no frequent stimulation. We are not doing as we should do in terms of rehabilitation, and all that hinder and restrict their development. Caring these children is quite challenging. There is uncertain therapy, uncertain benefit to burden of the therapy that we are giving to the patient. We have an evolving complex disease, usually rare. Either they are on very rare treatment we use with unclear prognosis, or they are on trial treatment with unclear response or unclear efficacy. Therefore, usually there is uncertainty between the benefit and the burden of the therapy on these patients, which may result in inconsistent understanding between and poor communication between the treating team and the families. As we said earlier, in ICU, it's a rapid ICU, high turnover, resulting into no clear big picture. We have competing, usually priorities. We have acutely sick patient who's dying, and at the same time we have this chronic, not much changing condition, but it needs attention, needs work. So there is this competing priorities which emphasize decision daily on a day-to-day rather than longer term plans. I think we are all guilty of coming through the bedside of the chronic patient. How is he doing today? He is good. Things are good. Alhamdulillah. We're going to continue what we're doing, and we'll continue looking for the as having another acutely ill patient. And there is no clear ownership usually for these patients. Chronic critical illness has a huge impact on family patients, healthcare, practice, our training and education as well. Healthcare system is usually highly affected. They have significant bed occupancy. I'm not sure why it's not showing here, but the occupancy has been doubled over the last decade, using significant of the cost that we have, and which represent small group as number, which constitute and consume most of the resources. This is one of the studies actually done here in Saudi Arabia, estimating the cost of long stay patients. The median was around 500,000 per patient per year, ranging between 3 million to 200,000 per patient per year, which is a quite significant sum of resources, which could be actually better utilized. And if you think of our own healthcare system, you can see that there is many areas of improvement in terms of caring for these patients. Many of these patients were could be treated in a long-term facility. If there was a good home care ventilation program, they would have been transferred to and so on and so forth. So this is the same group that published this. They estimated almost reduction of half of the cost if there was a well-developed home care system with a long-term facility or home ventilation program. Family patient and healthcare workers are affected by this. This is a very interesting study. Unfortunately, I don't know why it's covered. The name is Isolation in Parents and Providers and Patients with Chronic Critical Illness. So what they did, basically, they interviewed parents of chronically critically ill patients. They interviewed physicians who's caring for chronically critical patient, physicians, nurses, RTs, so on and so forth. And they came on with these themes of challenges. The child is usually cared in the ICU by default. Whenever he comes, he goes to the ICU. The family are facing repetitive stressors on top of the chronic stressors that they're living with. Clinician, as we said, they face the challenge between competing priorities: critically ill patient, chronic versus chronic high intensive labor patient, which they named as not ICU mortality. And sometimes there's a gradual decline in the care in the case of the patient with no clear interventions in terms of limiting care, in terms of goal of care for this patient. I'm just going to end with some quotes from this study. So, quoting a parent, she says, and she actually described her experience and frustration, saying, "I am the expert on her," meaning her child. At home, I am attending. So she's saying they are not actually listening to me. When I say she doesn't look well, when I say you should do that, we just should do that, and so on and so forth. And the same parent says, "I know my child. I know what she needs. If they would just listen to her." On the contrary, the providers were quoted saying, "It's hard to maintain focus on the kids who is not changing. It's a chronic. I have a high acute unit. I need to care for this critically ill patient, and at the same time, I have this chronic patient who needs time. Who needs. It's not that they don't require our attention. It's just it's more slower pace compared to the rapidly evolving critical patient, which result in usually delaying planning, delaying, for example, procedures or surgeries or whatever for this patient until the time allows in the ICU. Take-home messages: pediatric critical care illness, pediatric chronic critical illness is an increasingly growing population. It requires certain skills and expertise that we need actually to train and teach new generations of physicians. Healthcare system need to adapt, need to develop to better serve these patients and decrease cost. I think eventually
Hello, I think we lost the volume, we lost the sound, Dr. Muhammad. Hello.
It's definitely needed to probably makers and practitioners.
Yeah.
And with this slide, I would conclude, and I will be more than happy to hear your feedback, your points, your experiences, and any comments.
Okay, very excellent presentation, Dr. Muhammad. We enjoyed it. Really, I enjoyed all through. It is very, very thorough and detailed presentation about chronic illness in critical care setting. I know there will be a lot of comment, a lot of discussion. The floor is open now. The one who want to comment, just raise his hand and we'll allow him to speak. And when you speak, please tell us about yourself, where your name and where are you working now? And now let's start the discussion. Okay, we have Dr. Hani. You are unmuted now. Unmute yourself, please, Dr. Hani, and mic is yours.
Assalamu alaikum. Thank you very much. Thank you for this very interesting topic, Dr. Mazid. Really enjoyed it. MashaAllah, you went from A to Z in a very comprehensive way. One issue I will just, so first of all, let me congratulate you on this achievement. Really, it's something that needs to be tackled, and it costs us a lot of beds, resources, and we have sometimes our long stay patients inside the PICU, and you have acute cases in the ER or waiting OR, and you cannot manage. One of the issues I notice is the family, the family becomes disconnected after a while. So initially you are seeing them on a daily basis, times, and it starts to become weekly, then maybe bi-monthly. And unfortunately, that's one of the maybe issues here that could be addressed in the future, looking into our own situation. So if you have any suggestions or comments on this aspect. Thank you again, Dr. Muhammad.
Dr. Muhammad. Okay, Dr. Muhammad.
صوت واضح دكتور عبد الله؟
Yes, clear. He asked, Dr. Hani asked about family disconnection for the chronic illness. Yeah. Okay.
Gracias, Abu Umar, Dr. Hani. But I agree with you. And this is part of the communication challenges that the team face. It's either the family are super involved with the patient, they know him very well, which is good. We like this. They are part of the team, and we view them as part of the team, and they usually expert in their patients and in their kit, especially if they have a rare disease that we don't see usually. So usually have more expertise about them. However, as you said, some parents, some family will be disconnected with these patients. I think the answer is to look at why they have been disconnected. Is it a result of this chronic stress they are living in? They are always with this child at home. It's high labor, high intensive labor for them, and they're using it during this time in the ICU as a respite for the patient as well. So I think we need to take it from both aspects, from the healthcare system aspects, from the family aspect, and try to support these families and try to understand why they have been distant from their child. It might not be as bad as we think, that we're just emotionally disconnected, they are not interested, neglecting. It might be there is something beneath this. I hope that's answered the question.
Yeah, it's clear. I think that also, if you allow me to comment, the communication played a major role here in this matter between the health provider, the patient, and the family. Yeah, now we have Dr. Abdullah Al-Wadai. Dr. Abdullah Al-Wadai, you are unmuted now. You can unmute yourself. Mic is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Abdullah. Thank you, Dr. Muhammad, for this excellent presentation. I have two questions. I need your help. Decision when to treat pediatric patient is one of the most difficult decisions I face in my practice. And as you said, in adult, it's maybe easier because when the adult fail, they fail mostly because of respiratory. While in pediatrics, it's a very complex decision. You're dealing with heart and sometimes nutrition that fail the patients easily rather than the lung itself. So from your experience, can you give us the guidelines when and how do we decide when to treat patients in general and specifically in cardiac ICU? The other thing, as you elaborated very nicely in your talk, those patients occupied almost half of the beds in our units. And as you said, they unfortunately get neglected with time because, as you said, we tend to deal with a more acute and requiring care of other patients that who comes sick and leave early. While those patients, because the round turnover in the ICU is quick, they tend to be forgotten by different shifts. Do you think it's time to consider, I have seen this in some hospital, they establish a specific unit in the same hospital dealt by the same group called chronic care units, where led by mainly senior nurses and RTs, but there is also a doctor who take care of the patient for longer period of time, so they can tackle their chronic issues, and maybe this will help them to get out of the ICU quicker. What's your thought, Muhammad, about this thing?
I'll take care of Dr. Abdullah. I think very excellent questions, very challenging questions to answer. I'm not sure if we'll have the answer to them. For the first question about trach, in terms of when to trach, it's really it's a harder decision in pediatrics, as you know, for many reasons. The impact of traching a child is way more than traching an adult. First, it's a higher risk procedure, have more complications. Caring for this is harder at home by the family, and it affects their development for the child in terms of talking and language development. Therefore, the decision is very hard on that. Unfortunately, I might not have a straightforward answer. I hope I can say a specific number. However, I think it needs to be considered thoroughly in terms of benefit and risk, and taking it in context of the healthcare system that we work in. Sometimes maybe waiting on the patient for improvement will be a more feasible option if the underlying disorder is not static or progressive worsening. So personally, I am from the group that waits, especially in like an ARDS kind of picture, only like lying, purely lying. I usually tend to wait. However, if a patient is, let's say, an airway, neurologically deranged or requiring ventilation, the answer becomes easier in terms of tracking them. I'm sorry I didn't give a clear answer on that, but I think that reflects the status that we are facing and working in. For the other question about having a dedicated team in dealing with this patient, when I reviewed, during my review, some center have multiple approaches to approach these patients. One of the approaches I have faced and I have practiced somewhere else is actually having a primary intensivist for a patient. Let's say you are working in a unit, you have a trigger, like let's say patient stays more than 3 weeks. خلاص, once the patient stays more than 3 weeks, automatically assign a primary attending from the intensive care unit. His role is clear. He oversees the overall picture of this patient. He could coordinate the long-term plans of this patient. He connects and communicate with other subspecialists regarding a chronic or longer-term plan for this patient. A day-to-day management is usually done by the consultant on service, while the big picture, the communication, consistent communication with the family about major decisions are done through the primary consultant or primary team, which is the consultant sometimes with a fellow as well. So this model provides a good communication with the family, consistent communication with the family, and the person who oversees the big picture. Other approaches, as you said, either to develop a specific team that cares for this patient in either separate unit or a same unit. But I think in our context, the Saudi, I think we have a long way in developing other supported services. One of the things I faced is not having a well-established home ventilation program, not well-established trach patient program, complex care program. So we really had a hard time discharging these patients from the units. A patient who is trached, chronically ventilated, he stays with us, he's only because he needs the vent. In other healthcare system, he might have gone home on the hand ventilation with a good follow-up. And here you see the definition of chronic critical illness will change in the context that you work in, which consider maybe here chronic might not be considered in other areas.
Good. Clear. We need to move on. Dr. Ali Al-Harbi is raising his hand. Dr. Ali, mic is yours.
Yeah, thank you so much. And honestly, Dr. Alham before me. So if Dr. Alham allow me, I prefer to go by after Dr. Alham. I think Dr. Alham before me.
Okay, sure. Okay, Dr. Ilham, mic is yours now.
Thank you for the speaker for the great presentation, and thank you, Dr. Ali, for allowing me to speak. Just a comment and also a question. You think that these chronic patients, especially the most problematic one with neurological illness that we keep on a ventilator in the ICU, are just in the wrong place? Like the technology has advanced, and the ventilator, I think of it now in a chronic ventilator setting, is like their insulin pump. And even sometimes some of the home ventilators are very easy to use, but the acceptance even within hospital settings, like for example in the ward, or even for the family, they think of it as a great burden that cannot be sort of cared for. They're in the wrong place, and we're keeping them in ICU settings, whether in long stay units or even in the ICU. They're still on monitors for a long time, frequent vital signs. They don't need this level of care. They need different care. For example, those with SMAs would need schooling, physiotherapy more to live a normal life, or as much norm that we can get them. Getting them into an ICU, even a long stay unit, is a wrong thing to do. So maybe it's time to get them out of the ICU and in chronic care facilities that stimulate sort of a home environment, and from there facilitate their discharge from home, because an attempt to discharge them from the ICU gives the impression always that they need this level of critical care, they need this ICU setting, and they don't need that. And the second thing is that since we don't have the supportive care, should we be doing as much tracheostomy in patients? I think we're actually very quick to take the decision in neurological patients that we stick them on the ventilator for years. And we don't take this decision in patients with acute illness that may benefit actually from the trach. And our thought of this maybe should change. Thank you.
Thank you, Dr. Ilham. Dr. Mohammed, you need to answer this.
Excellent points. I cannot agree more with the first point about needing for chronic care facility resembling home. And with the trach, I think you're raising a very interesting point. I cannot agree more.
Yeah. Yeah, Dr. Ilham, any comment or we move on?
Yeah, thank you for the comment, but I just want to say, what are your thoughts about sort of the DNR acceptance in patients with neurological illness? And is it the family unacceptance of that is pushing us to putting the patient on trach and just keeping ventilated, like we're taking the easy way out? Thank you.
I think we are arranging another presentation soon about decision in chronic illness patient, like DNR status and care and decision making for this. It is huge things to be answered now. Let me ask Dr. Muhammad to comment about this. Okay, Dr. Muhammad, you can comment.
It's a huge question about social, religious, legal, medical aspect to answering it. And I don't think we'll have the time to talk about it, but I agree with Dr. Ilham in the notion that we might be over treating some of these patients in an invasive way.
So we'll move on now, Dr. Ali. Mike is yours, Dr. Ali. Dr. Ali Harbi is our co-host, and he's arranging all this presentation technically and personally and medically also. Dr. Ali, Mike is yours.
Thank you so much. I really can say Dr. Muhammad is so attracted on the talk, is really needed, I feel. And you touch, I feel, our need, I can say. And probably something we need to focus on future, because we think about something as inside the ICU border, but we did not think something outside the ICU. And thank you for bringing the definition of the chronic care about readmission to the ICU. True, the readmission in the ICU is common for these cases. Accept my question, because you are attracting me a lot. So the first thing is, I'll go by home care facilities. Do you prefer home care facilities have and somehow leaded or controlled or provided by ICU medical team, I can say, or special team for those cases? And I also have a further question.
Yeah, Dr. Muhammad.
Yeah. So thanks for your answer, Dr. Ali. In terms of leading the long-term facility, I'm not aware. I didn't look up the evidence or literature on this, if it exists, about who better lead this. But I think having a person with the skills and expertise in terms of working with chronic patients with critical illness, whether either in a ventilation expertise, having the ability and the skill to summarize complex issues in a very clear, goal-directed manner is important. Where I worked previously, what I have noticed is who oversees and arranged this, or who initiated this in the place where I worked, was actually intensivist who used to work as an ICU, and prior to retirement, like 5 years, 10 years, they shift the gears to care for such patients with a chronic illness. At least 2 or 3 of them are previous intensivists. They switched their career in terms of looking for chronically ill patients and home ventilated, home setup, long-term facility.
Okay, we'll move on.
Yeah, I have some question also.
Okay,
yeah.
Okay, go ahead.
Very, very, very quickly. So the second case, I think Dr. Abdullah, he touched based on that, certain spectrum of disease, they will go by, they need a creative team or a supportive team inside the hospital, and probably as follow-up, single ventricle physiology, because the mortality from there is high. Also neuromuscular disease. Do you believe creating such team will help to decrease the burden on the ICUs?
care team, for example, if you would call it, in some areas, yes, definitely they will take some of the burden. They will see the patient more regularly, usually as an outpatient, which eventually decreases the risk of their infections, their decompensations, and so on and so forth, which I think we are lacking in our context. I'm not aware if there's any comprehensive program such that, at least in Riyadh.
Yes. And the other thing, Dr. Mohammed, I'm just asking about unifying the eligibility could help, like, to have better chronic care support. And last question is, would you think about focusing toward facilitating faster diagnostic tools to enhance, like, the diagnosis for certain cases, like congenital cases, will probably help to decrease, like, chronic care burden on the ICUs? And that's my last question. Sorry.
Point, yeah, I think there is some growing literature on that in terms of the role of early diagnostic, molecular diagnostics specifically, like wide exome sequencing, for example, and more rapid access to genetic diagnosis and how this affects care in critical area. I think there's a wide and there's growing interest on that subject. Unfortunately, I'm not aware of any. يعطيك العافية دكتور علي.
Now we'll move on. Dr. Hani, you have another question, and after that, Dr. Hanan. So, Dr. Hani, mic is yours, as brief as you can, because you have less than 10 minutes to conclude.
Very brief. يعطيكم العافية. It's just a notion again, since it's a very common issue, it looks like a common issue among the whole PICUs. So I really recommend if our societies, the pediatric critical care, the pediatric cardiology critical care, if they make like a task force and make a recommendation, national recommendation. Again, it's just, but because I noticed even Dr. Wadi asking when to take, what is the definition of our long-term chronic patients? So I think having a national, like drafting a task force recommendation guidelines, I think that can help. And it can unify our efforts together. So you are trying not only to resolve this problem, you are trying to improve the quality of life for these children, from the PICU to maybe long stay units in the hospital, going to a home care. So I think that could, I'd really, so you already addressed half of the problem. You already have half the solution is there. So if the societies can recommend this, take a task force. So this is my recommendation for you.
Good.
I wonder, yeah, thank you again.
Thank you, Dr. Hani. Dr. Mohammed?
Okay, Dr. Hani, I agree, but I think before going that, even we need to quantify the issue we have. We need to clearly collect data on these patients, see what are the challenges that we are facing, see how big the issue is. And with this, we achieve two things. First, making insightful recommendation based on real data that we have from our local context. Second, making a case with clear numbers to the policymaker and either on the level, national level, probably, or local level in your hospital.
Yeah, okay, Dr. Hanan, you can unmute yourself, yeah.
Assalamu alaikum. يعطيك العافية Dr. Mizid. It was a great presentation in very interesting subject. Just I like, because you are talking about internationally, I want to tell you that we have this experience at the Prince Sultan Medical Military City. Has a good experience for many years in the home care facility. They are doing very good job in that, mainly with the adult. At the same time, 5 years back, I was involved in many, almost 5 meetings with Dr. Yasser Mandoura, who was setting a program for, we can say it's مشروع for a building of 150 beds only for the chronic patient, and they involve us as a cardiac center to tell how many chronic patients we have. because as you said, it is not fair to fill our ICUs with the patient who stay longer time and now they need a special need which can be cared by nurses and medical doctor or fellow trained in the chronic patient. This program, I think it's still in the process. Maybe the corona delayed it, but there is a program related to have a special hospital mainly for the chronic patient, and this is in the city. And at the same time, this will open us or lead us to think about, maybe we have to think about a special program related to only chronic ICU patient rather than a critical ICU patient. Thank you.
Thank you, Dr. Hanan. Dr. Mohammed, any comment regarding this?
Hanan, I'm glad to hear that such a project exists, and hopefully we'll have something on a national level as well, inshallah.
Okay, we have Dr. Tariq Al-Aid. Dr. Tariq, mic is yours.
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh.
Jazakum Allah bil khair. Thank you, Dr. Muhammad, Dr. Abdullah, and the whole chapter of pediatric cardiac intensive care. Enjoying the talk. Just comment about chronic care facilities and home health care program. I think part of the issues is not only establishment of chronic care facility. Whenever you are going to establish these facilities, is going to be filled with patients. You know, even if you open an institution of 50 beds or 100 beds or whatever, probably is going to take a couple of months or years until it's going to fill, and then probably are looking for another institution. And I think it's part of our responsibility as healthcare provider, trying to figure out who is really needing chronic care facilities or who is needing a home health care. I think there is two variety of patients that either they need to go through, you know, initiation of palliative of care, end of life decisions before we move them to chronic care facility. If you're looking at least in the kingdom, and you could see how many peripheral hospitals is being filled with, you know, patients who have been trached for, you know, a couple of years. Their units have been filled, and then when there is a life-threatening patient who just normal patient develop sepsis or septic shock, probably he could die in his primary hospital because there is no bed in this hospital. And majority of this hospital is filled, and even they expand, they open another unit for a chronic care facility, it will be filled. And I think we shoulder the responsibilities. You know, we are the one who's directing the family where to go. And sometimes we are, as a physician, hesitant to explore palliative care end-of-life decisions. So I think we know that there is some patient who's probably difficult, but at least trying to move in direction of palliative care is probably a very acceptable plans. And you could see internationally, they don't have a lot of, you know, chronic care facilities. Most of them, the decision had been made earlier before they moved to this chronic care facility. On the other hand, patients who had a normal cognitive, a patient who is chronically ventilated for some other reason that there might be a chance of improvement, this is the way that we probably need to augment and to encourage having a home health care facility. I don't think the answer is just to fill up units, keep patients in the ICU. We really need to move them home. And majority of families that through program of home health care, you know, there is a resistance at the beginning, but later on, when this patient tried home, they will see the difference. And then when they're coming back to the hospital for a reason or another, they always like to go home because they know they will see what is the difference between home and the hospital. Thank you.
Thank you, Dr. Tariq. Dr. Mohammed, you need to comment about Dr. Tariq.
Yeah, Dr. Tariq, I totally agree. I think the solution needs to involve many aspects of the healthcare system, not only creating a long-term facility. As you said, it's just going to move the problem from area to another area. While if we have a comprehensive solution to this, patients who require the chronic care facility will go to it. Patients who will benefit and will thrive better in the home care setup, we should enable that and initiate excellent home care programs, and as well setting a reasonable level of care goals for our current patient. I totally agree, and I couldn't make it nicer than you did, Dr. Tariq.
Dr. Mohammed, my last questions, I have two questions or two comments. We know all that the neurological outcome and developmental outcome is the most important aspect of this pediatric patient, chronic patient. So, and we know that advocating a friendly home-like setting, ICU, is the most important in the development and the neurological outcome in this kind of patient. So do you go through any program outside the kingdom in the Western countries that adapting a family friendly ICU setting that can be adapted in our ICU here in the kingdom? Is there anyone exist that we can be adapted in all the hospital here after this corona pandemic era? The other question will be one of the suggestions that if we have a patient who's chronic, who's more than 3 weeks, do you need to suggest this patient to be taken care of one attending that he knows this patient well, he can plan him? Because I think the flipping of the care every week, as all the ICU doing every week, one attending will take over. I think it's clearly will affect the outcome of this chronic patient. Every week, the one will come and he will not start from the start, and he will just go very quickly through the whole problem of this patient. So I need your comment about these two issues.
There is now a huge emphasis on the need of rehabilitation practices in the ICU. But whatever we will do, it's not going to be very replicative or representative at home to eventually result in a delay. So I think the best solution for such cases who are chronically ill is to try and simulate a home setup, either in home care programs or a longer term facility. Because you need to be honest, and usually we wouldn't have the time or the human resources to do such. If we did it 1 or 2 days, we're not going to do it with others. If we have more than one sick patient, the whole unit is in one bedside or another bedside. I think I agree. The rehabilitation and mobilization and activation and stimulation is very important, but I think it's very hopeful to achieve something similar to home. I think it's very hard. For the other question, Dr. Abdullah, was about what was the
to announce or to asserting one attending for a chronic patient and not to be flipped every week.
So that in some centers, what they do is after a certain criteria, whether it is time with the transition of the care of the patient to a more chronic setup, they will assign one physician as being the primary. However, he's not going to see the patient every day. Day to day is the attending physician on service, which I think is reasonable. Because eventually, if you do that, everyone will come every day to the bedside for one of our other patients. And I think its importance is to have a clear criteria when to assign and what's the clear role of that physician or team.
Good. Thank you, Dr. Mohammed. I think we are over. Dr. Yasser here. Last comment will be, okay, Dr. Yasser Hirsch, mic is yours.
السلام عليكم.
عليكم السلام ورحمة
الله. شكرا دكتور محمد for the excellent presentation. Dr. Abdullah and all the team organizing such excellent meetings. I will not add more. I think my colleagues they covered everything related to this very challenging topic. That's impacting the resources and the costs and everything. We basically see such patient every day. I think, I agree with Dr. Tariq and some of the colleagues that, we are participating in the decision of what's the exit for those patients before they get in chronic illness. Such in the cardiac setting, those patients, they have either comorbidities, difficult or complex cardiac disease. And then we decided to operate on those patients. Then we faced that, they have complication after the cardiac surgery, they stay longer, they get trach, a system tube, and then, they took long journey in our unit and they park in our unit for a long time. That's affect for sure the overall healthcare. So I think I agree, which is very important to patient selecting before we decide to operate on those patients if we know that this is going to be their path. So that's in the cardiac setting. And then you discuss, as Dr. Tariq, I agree, discuss the end-of-life care and palliative care. And you keep this in your mind as early with involving the family. I have some experience with those patients. Recently, I have transplanted patient, had heart transplant, two of them. One of them actually have very weak, two of them actually, they develop ICU muscle weakness. It was difficult actually to separate them from the ventilator. Eventually I have to trach them. And after a couple of weeks, I think they are ready now to be decannulated and to go home. So those patients, we know that, predict that maybe their, outcome will be different. But I think in general, we still have hope for some patients in cardiac population where they can have, either long stay as a chronic, or they can stay shorter and then can be discharged earlier. I think it's a difficult decision, but I think, we always have the decision early and be brave to make it clear and speak up that those patients, they are not operable. And I think, difficult, and discuss with the family, counsel them very well, and then make it clear. Thank you very much.
Mohammed, any closing comment?
I think it's very excellent point again. I agree, managing expectations of parents from the beginning is very important, especially in your context of cardiac surgery. And, sometimes patients will have a complex heart disease and he would have other congenital anomalies that actually might hinder him even after correcting his cardiac problems. So I think patient selection, clear expectations, reasonable expectations of recovery are very, very important. And thanks all for this. Thanks.
I promise that we are going to arrange a next session about end-of-life care and DNR status by professional doctors in our group that will present maybe next month. We are going to continue our presentation on a monthly basis from the Saudi Pediatric Critical Care Society Cardiac ICU chapter. I would like to thank Dr. Mohammed Al-Mazyad for his very, very nice presentation, very touching topic. And I would like to thank all the attendees. We reach 150 participants today or tonight, and it is endless, the discussion today. And I hope we'll meet again next month. I would like also to thank Dr. Ali Al-Harbi, with all the support and organizing and doing all these activities, and all the committee in the Pediatric Critical Care Cardiac Critical Chapter. We hope we'll meet again next month. Dr. Mohammed, last closing comment. Thank you so much, Dr. Mohammed Al-Mazyad.
It was really my pleasure to be part of this activity. I'm looking forward to the next activity already. Dr. Abdullah, it seems to be a very interesting topic. Inshallah, we'll enjoy it with whoever presenting it. Thanks a lot, Dr. Abdullah.
Thank you so much. Thank you for you all, and have a quiet night. Go home, sleep early now, and meet tomorrow in the ICU. Thank you so much. we'll end the session now. Thank you.
Thank you, guys.